So good afternoon, good morning, good evening to everyone. Once again, welcome to our EPI-WIN webinar. Thank you for joining, particularly those of you joining from far away or at late or early times. Thank you for joining this webinar on the global update on COVID-19, managing the risks from new variants. We have today experts on this field, and you'll be able to, there's ample time for you to ask questions as well. For those of you who are new to EPI-WIN though, this is the WHO Information Network for Epidemics for Science and Knowledge Translation in Health Emergencies. With these EPI-WIN webinars and the associated EPI-WIN digest slide sets, our goal is to translate science in accessible, understandable, and relevant ways so that people can take evidence-informed actions and decisions during an emergency in health emergency preparedness and response. So welcome once again. Today we have a great panel. We have Dr. Sylvie Briand, Director for Epidemic and Pandemic Preparedness and Prevention at WHO. And this was really her vision. She's a great visionary. We also have a very familiar face for COVID, Dr. Maria van Kerkhoff, who's the unit head for emerging diseases and zoonosis. We have Professor Anne Votgotberg of the National Institute for Communicable Diseases in South Africa, who's also the vice chairman of the Technical Advisory Group for Virus Evolution for SARS-CoV-2. We have Dr. Meera Chand, who's the Deputy Director at UK Health Security Agency, and also another member of the Technical Advisory Group for Virus Evolution, and Dr. Lorenzo Subisi, Technical Officer for Emerging Diseases and Zoonosis. Without further ado, I will hand over to Sylvie Briand, but just before that, a few housekeeping. This webinar is being recorded and interpreted in 7 languages, in Spanish, French, Russian, and in AI interpretation in Chinese, Arabic, and Hindi and Bengali. So if you would like to ask questions, please put your questions in the Q&A, and please introduce yourself in chat because we would love to know where you've come from. And finally, if you would like a certificate, please respond to the survey at the end of the webinar. So much for housekeeping. Over to Dr. Sylvie Briand. Welcome, Sylvie, and the floor is yours.
So thank you very much, Supriya. I mean, EPI-WIN is also a teamwork, and you see different faces contributing to different webinars, and I just would like to highlight this as well. But for today, I would like to wish you first good morning, good afternoon, and good evening, and thank you all for joining us today for this EPI-WIN webinar. It's always a great pleasure to welcome you, and in particular today for this new discussion on ever-evolving topic of COVID-19 variants. As you may know, today's discussion revolves around the various forms of SARS-CoV-2 virus. Currently, we found ourselves dealing with Omicron variant. However, within the Omicron family, if I may qualify it that way, and Anne will tell me if I am wrong, but in this family of Omicron, there are a lot of different branches. And we named them with numbers and letters, so it might feel very complicated, but the expert today will explain everything about this. But we have XBB 1.5, SBB 1.16, EG5, BA2, and different descendants from this variant. So Omicron, fortunately, is less virulent than the ancestral strain that emerged in 2019 and spread in 2020 around the world. However, it's crucial to acknowledge that even though Omicron may be less virulent, some individuals still can develop severe disease when exposed, for instance, to a high density of virus or due to special risk factors such as diabetes or weakened immune response, and particularly among the elderly. Therefore, our caution with Omicron should remain, even if its characteristics are less alarming than those of previous circulating variants such as Alpha, Beta, Gamma, and Delta. Since the antiquity, humanity has been fascinated by both the macroscopic world as we gaze upon the stars and the microscopic world has always wanted to understand them. Democritus, way back in 400 before Christ, introduced the theory of atomism, which posited that matter is composed of indivisible and eternal atoms. However, it's only in recent times, when the remarkable advances in technology, that atoms has been observed and studied. Similarly, in the field of biology, especially with new technology like genomic sequencing, we have been able to dive deeper into the microscopic realm. Today, we possess the technologies necessary to better understand viruses, which is of paramount importance when dealing with pandemics. Understanding the virus, its evolution, and its behavior is crucial for humanity to better develop tools such as vaccine, treatments, and tests to mitigate the impact of pandemics. As the virus evolves, we need to make sure that our tools are still useful. I vividly recall the first weeks of the pandemic when we discovered that the culprit behind COVID-19 was a coronavirus. At that time, I asked some virologists whether they believed this virus would evolve rapidly. And this was drawing on my experience with influenza viruses, which are numerous and frequently undergo reassortment and evolution. And at that time, they expressed doubt that SARS-CoV-2 could evolve rapidly. However, as we have witnessed during the course of the COVID-19 pandemic, coronaviruses indeed have the capacity to evolve rapidly. Perhaps this is due to their intensive circulation among human populations, or maybe a result of our improved diagnostic capabilities, allowing us to better understand their changes and the dynamic of viral populations. Regardless, it's imperative to continue to monitor those viruses, gaining insights into their evolving abilities and understanding how they might escape our tools. This knowledge will help us to better control the disease and better prepare for future pandemics. Now, I'm honored to introduce you to a panel of top-notch experts who will delve into the intricacies of the virus, its potential public health impact, and the strategies we can employ to combat it effectively. And together, we shall navigate this challenging terrain with knowledge, resilience, and shared goals of a healthier and safer world. So thank you again for joining us, and let's embark on this journey of discovery and preparedness together. Thank you. Over to you, Supriya.
Thank you very much, Sylvie, for setting the scene so nicely with where we are with COVID and how we can move forward with that. Now I hand the floor to Dr. Maria van Kerkhoff, who will give us an overview of the global situation. She will be followed by Professor Anne von Gottberg, who will explain to you the risk evaluation tools, and then we will have a panel discussion and Q&A with all our experts. Over to you, Maria.
Thank you, Supriya, and thank you, Dr. Sylvie Briand, for setting the stage. So I am really thrilled to be joined by Anne and Mira and Lorenzo, who play such a critical role in our technical advisory group for virus evolution. I'm going to start the presentation, and then I'm going to hand it over to Professor von Gottberg, who is our TAG-VE co-chair from South Africa. Special thanks to Mira Chand, Dr. Mira Chand, who's joining us as a member of TAG-VE, but also plays a critically important role in the UK and in the world in terms of understanding viruses. And Lorenzo Subisi, who's part of my team, so fortunate to have, who does a really incredible job of coordinating TAG-VE. So with that, I'm going to give you an overview of the current situation, but this overview of the current situation is very narrowly focused. It's really focusing on epidemiologic, circulation, the variants themselves, and a little bit on impact. This slide set does not cover all of the work that WHO is doing in terms of clinical management, in terms of infection prevention control, ventilation, vaccination, et cetera, et cetera. So I just want to frame that to let you know that we could do updates for these other topics at another time, but we really wanted to remain focused on the viruses themselves. So where are we? You all know that the public health emergency of international concern for COVID was lifted on the 5th of May, 2023. This is following more than 3 years of being in this crisis phase of COVID-19. And while the Director General declared that the emergency of COVID is over, he said that the threat posed by COVID-19 is not. So this is the latest EPI curve that we have. And what you can see on the left-hand side there is the EPI curve looking at the reported number of cases since the beginning of the pandemic. And if you look at this slide carefully, it looks like COVID is gone. It looks like the virus is not circulating anymore. On the right-hand side is a blow-up of the last several months, and we are still seeing millions of cases reported to WHO. And these are infections and reinfections. But we only have data coming from 93 countries and territories out of 234 on cases. In terms of deaths, we've seen a sharp decline in deaths of COVID-19 over time. And this is due to a number of factors, including increasing population level immunity, access to clinical care, better diagnostics, and importantly, increased population level immunity from infection and from vaccination. But right now, WHO only has data on deaths from 40 countries out of 234 countries, territories. This might suggest to some that the rest of the world is not seeing cases and are not seeing deaths. And we know that that's not true. We know that the virus is circulating in all countries, but we don't have good visibility right now on how much circulation is actually happening. In terms of cumulative cases, more than 770 million cases have been reported to WHO, which we know is a gross underestimate of the true number of infections, which is in the billions. In terms of deaths, more than 6.9 million deaths have been reported to WHO. And there are estimates that suggest that that could be upwards of 3 times higher. So this virus is still very much with us. It is still circulating, and it is still causing infections, hospitalizations, and death. One of the ways in which we're trying to track trends is looking at over time and looking at the change in the last 28 days or the last month or so. And we break this down by WHO region. What you can see here, with the limited information that we do have from the small number of countries that are providing this, we do see some increases in deaths in some regions, and this is quite variable. It does take time to get reports on deaths because it takes time for the patient to reach their outcome. We can say with certainty that the impact of COVID-19 has reduced since its peak, but there are still a large number of individuals who are infected, who are needing hospitalization, who are needing advanced care, who are suffering from post-COVID condition, and who are dying. And we feel there's much more that we, together with our member states, can do. So in the backdrop of declining surveillance and reporting, we have also been utilizing the global influenza system, GISRIS. So this is the Global Influenza Surveillance and Response System, which expanded in scope to cover not only influenza, but also SARS-CoV-2, the virus that causes COVID-19. And looking at how we report on not just flu, but we report on both COVID and flu. And these are just some examples that come from the dashboard from the Global Influenza Program, looking at specimens that are tested and how many of those are testing positive. And on the right-hand side, you can see that it's anywhere between 12 and 14% positivity of those individuals who are getting PCR tested through this Sentinel and non-Sentinel-based system. That's still quite high. So we know that the virus is circulating. But we're just not able to detect it and report on it as clearly as we would like. We have shifted to look more at impact, and what we really would like to do and what we need help from our member states on is information on hospitalizations and admissions to ICU. So this table is another example of how we are tracking these trends. And what you can see on the bottom, on that bottom row, if you can see my cursor at where it says global, we only have 22 countries out of 234 that provide data on hospitalizations. Much of this is not reported to WHO, but coming from national websites, which we are pulling from. And most of that data is coming from the Americas and in Europe. And in the countries that are reporting, they are reporting increases. Again, this is variable over time. What is worrying for us is that this is ahead of the autumn season in the Northern Hemisphere, where people spend more time indoors, where there's poor ventilation, where pathogens that transmit through the air take advantage and really find ways to circulate more efficiently. And we provide those opportunities in the colder months. On the right-hand side is ICU admissions. These are very small numbers, very small number of countries that are providing this, but it is worrisome when we do see increases. This is just looking at the same type of data over time. So you can see from the top graph there that we did see an increase in hospitalizations, weekly reported hospitalizations over those summer months in the Northern Hemisphere. And again, that is quite concerning. Maybe we've reached a little bit of a peak, but we have to, the last couple of weeks of data are quite limited. There's usually a backlog in terms of that data coming to WHO. So we don't have as much visibility on the virus's circulation and the impact that it has. So one of the main points in bringing you together today was to talk about the variants themselves. So you've heard us say many times, the more the virus circulates, the more opportunities it has to change. And we, together with our partners around the world who are working in surveillance and research, with our technical advisory for virus evolution, TAG-VE, have been monitoring the circulation of these variants to rapidly detect new variants and to monitor the ones that we know are in circulation. Currently, we're tracking 3 variants of interest: XBB.1.5, XBB.1.16, and EG.5. These are all part of the Omicron family. We have several variants under monitoring that we are tracking as well. We can say that the 2 XBB variants of interest are declining or stabilizing, but EG.5 is on the rise. And I can say that not one variant is dominant worldwide. So there's a lot of different viruses that are circulating. They're all SARS-CoV-2, and they all could cause the full range of disease, from asymptomatic infection all the way to severe disease and death. And our interventions are working most critically. What is concerning for us also in terms of reduced surveillance and reporting is the reduced number of sequences that are available to be analyzed. And this is illustrated in the upper figure here on the left-hand side. But it's not just the number. It's not about more sequences. It's about having good geographic representation of the sequences for our experts to analyze. And we need to make sure that they come from a variety of countries, a variety of different settings, and that those sequences are reported in a timely manner. So not only are the numbers declining, the geographic representation declining, but the amount of time it takes for a sample to be collected, a sequence to be carried out, and for that information to be shared on a publicly available platform, that time is getting longer. So this reduces our ability to produce timely and robust rapid risk assessments for these variants. This is just another way of looking at the variant circulation by region. Very hard to see there, but we wanted to illustrate that the variant trends are very different globally. And the impact of each of these variants as we evaluate them may behave slightly differently in different populations based on what was circulating before. Past variants of concern, alpha, beta, gamma, delta, and the Omicron sublineages. Did a population experience BA.1 or BA.2 or BA.4 or BA.5 or both, or XBB? So it very much depends on what was circulating in the past in terms of the impact, plus the amount of coverage we have for vaccination. And not only that, but when did people receive their last dose of vaccine? Because we know there's waning immunity over time. There's a lot of attention right now to variant under monitoring, BA.2.86. We have less than 200 sequences that are available for analysis, coming from 21 countries across 5 of WHO's regions. We have limited information on BA.2.86. It was classified as a variant under monitoring because it had a large number of mutations in the spike protein. And so we quickly labeled it a variant under monitoring. What we're not able to estimate growth rate, but what we can say is, given that it's been detected in 21 countries, we know that it is circulating. But what we can also say is that so far, we have not seen it outcompete the other variants of interest that are in circulation. So it's still very low numbers, and we're working with our TAG-VE meeting very frequently to discuss this and any updated information. And we're so grateful for countries who are continuing to report on this. So as I mentioned, the sequences that are shared through GISAID, this is a publicly available platform to analyze these sequences. these numbers have declined over time. And not only amount, but where they're coming from. You can see on the bottom there, not just a decline in those colored lines there, but the proportion of countries that submit sequences varies greatly by WHO region. And so what we need to do is increase and have what one of our colleagues calls intelligent sequencing, so good geographic representation, so that we can look around the world at what is actually circulating and be quicker at detecting new variants quicker. Same way of looking at this, but right now the majority of sequences are submitted from three of our regions, the region of the Americas, the European region, and our Western Pacific region. So we need to increase the proportion of sequences that come from our other regions, again, so that we have good visualization. So WHO continues to work with all member states, and we issued an updated global strategic plan focusing on a 2-year period. And this is to support countries in transitioning from crisis mode while we were in this public health emergency to longer-term disease management. The objectives are listed there, which are similar to the objectives we've had since the beginning: reduce and control the incidence of infections, minimize severe disease, and reduce the impacts on the healthcare system. Because people that need beds for COVID are beds that are not available for people who need them for other diseases. And there's more that we can do to prevent those infections and severe disease. To prevent, diagnose, and treat COVID-19, to reduce mortality, morbidity, and long-term sequelae, including from post-COVID-19 condition or long COVID, and for us to support our member states. And while we were working on this, we're using a 2-year transition period right now to support countries to get to longer-term disease management. We're linking with even longer-term plans for updating pandemic preparedness. You had an EPI-WIN seminar recently on the PRET, or looking at preparedness and resilience for emerging threats, updating pandemic preparedness plans. You've had some seminars on the Mosaic, which is looking at different elements of surveillance in different countries to utilize the different components to meet different objectives. We're linking with a 10-year global genomic surveillance strategy because sequencing capacities have expanded greatly over the last 3.5 years, and we need to sustain these capacities for infectious diseases, for pathogens with epidemic and pandemic potential, not just SARS-CoV-2. And you may have heard about the IPSN, this network that is pulling together the different groups that are dealing with bioinformatics and sequencing so that we could provide a framework and more structure around using sequencing and the information coming from sequencing for public health action. I'm almost finished before I hand over to Anne, but I just wanted to reiterate and thank members of our WHO advisory groups who are working with us to assess these variants. So you're hearing from TAG-VE today, but we also have TAG-COVAC, which is the technical advisory group for COVID-19 vaccine composition, which is looking at the impact of variants on the current COVID-19 vaccines and determining whether or not any changes to vaccine composition are necessary. And we link with SAGE, which is our strategic group that advises on vaccination policies and looking at the strategies to deliver vaccinations, including COVID-19 and many others. So from looking at data to making decisions around vaccine composition to setting policies, we rely on people around the world and the data coming from countries to be able to make these, to monitor and assess each of these variants, especially as they relate to our use of vaccines, therapeutics, diagnostics, and effectiveness of public health and social measures. And last slide for me, on the 9th of August, our Director General, Dr. Tedros, issued standing recommendations for COVID-19, and they cover a variety of specific recommendations for member states in these key areas that are listed on the slide, A through G. I won't read each one of them, but these are largely focused on updating COVID plans, taking into consideration our updated SPRP, dealing with COVID in the context of so many other health emergencies, sustaining collaborative surveillance, making sure that countries are reporting data and impact data, vaccine effectiveness, so that we really understand the epi situation, the variant landscape, we can conduct our risk assessments, and we can support our advisory groups to help advise WHO on what needs to be done. To make sure we increase vaccination coverage among the at-risk groups, according to SAGE, our booster coverage globally is around 55%, but in the region of Africa, it's around 8% of people over 60 have received a booster dose. And what is really critical for us is not just when you received your boost, not only if you received your booster, but when you've received your booster dose. So please follow your national guidelines and get boosted, get that additional dose when it's time for you. We need to make sure we continue to do research, we continue to provide optimal clinical care, integrate clinical care into clinical care pathways, and to make sure we really focus on equitable access to safe, effective, and quality assured medical countermeasures. This is still not seen globally in terms of access to diagnostics, therapeutics, and vaccines for COVID-19. So there's much more work we need to do for COVID, but also for future threats. And I think with that, I will pass over to Anne. Over to you.
Thank you, Maria. And so I would like to continue next slide, just explaining a little what the Technical Advisory Group for Viral Evolution looks at. In fact, what all of our colleagues and public health experts are monitoring and looking at in order to look at what variants and lineages are emerging. Remember, the virus will evolve. That's an expected fact, and it evolves as transmission occurs in human-to-human transmission throughout the world. What is happening is what Maria said, is that less and less sequencing is happening. So we're seeing less of that evolution over time, and we'll only see once we get a specimen or a sequence in the unusual circumstances where we are getting sequences, which is in these routine surveillance systems that are now going to take over from what we were doing during the pandemic. In addition, we might get evolution in animal reservoirs that are not being monitored, and therefore if there's a zoonotic spillover from animals to humans, there may also be emergence of variants that we haven't been seeing. But really where quick evolution happens is when there's recombination in the virus that exists between that is part of the human virus that is being transmitted, or if there's persistent SARS-CoV-2 infection with additional pressure, immune pressure in immunocompromised individuals. Next slide, please. But to remember, at the moment, Omicron is what is circulating. All those different lineages were Omicron lineages, and they are here depicted in the orange, red, and yellow color. You'll see they're branching off quite substantially in a separate branch from the old lineages and sublineages, which are the blue and the green and the yellow lineages in the circular tree that you see, as well as in the far left, far right figure. So you can see that clearly Omicron is different to the other lineages. All the sublineages that we're seeing are related. They are all part of Omicron. And Omicron has the features of high immune escape. It has upper airway tropism, so it's moved away from being tropic to the lower airway, which is what the previous sublineages or variants were. And now we find that the tropism is for the upper airway. And it gives a disease that has lower severity, especially if people have prior immunity or are vaccinated. Next slide, please. So this looks complicated, but it's just reiterating the variants under monitoring and the variants of interest. On top, you have the 3 variants of interest that Maria's already mentioned. In green, you can see the color showing that the prevalence over the last 5 weeks that are depicted here, so from week 32 to week 36, is staying quite stable. There's an increase in EG5. It's going from 25.9% to 33.6%, and we have a reasonable number of sequences, 31,000. If you look at the variants under monitoring that's below, you'll see the blue colors showing stable or decreasing. In the green, you see the decreasing prevalences, and it's just the one in yellow, the XBB 1.9.2, that seems to be showing an increase in prevalence. You'll note that the one variant that we're talking about, BA.2.86, doesn't even have data of prevalences, and that's because the numbers are so small. So it's very useful when you're looking at these data, when you understand that we're talking about these prevalences, to understand that we have to keep in mind the number of data points that we have, the number of sequences, and when it's getting to too few data points for us to have very robust or very confident prevalences globally. Next slide, please. So what the TAG BE and other experts do is they look at, okay, what is happening with these sublineages or these variants that we're seeing are being detected, so they're emerging, they're new, or they're increasing. We need to look, does it have a growth advantage? Is there an immune escape? And does it cause disease, severe disease, more disease? And it really is, we're pushing for a public health relevance in these indicators. We want to know, what does it mean for the systems, the hospital systems, for the clinics, for our doctors, our clinicians, the people out there? What is going to happen to individuals presenting to their GPs? Is there going to be an increase in the number? And so the public health risk is really important, and we try and understand whether it's low, moderate, and high. And then we are trying to be very transparent and trying to say, well, what's the confidence in our assessment of this risk? Is it a low, moderate, and high? And you can imagine that with those low numbers that we've already shown you, that our confidence starts to get low. And it's only over time, when more and more cases and more time elapses, that we might have moderate confidence. And we also need more data. We need data from different laboratories, from different regions, to tell us about the immune escape and what they're finding in the laboratory. And these assessments can take time. So yes, we try and do something rapidly, but it is hard with very little data, and comprehensive assessments only happen once many weeks have passed and data has accumulated from different sources. Next slide, please. So the first thing we do is try to understand is, if something's detected, should we worry about it? And there's lots of people in here, even those that are monitoring sequences on GISAID help us, and they alert each other and they talk about it. They say, this is something new, this has lots of mutations. Should we be making this a variant under monitoring? And we used to say that there needed to be a growth advantage, there needed to be lots of numbers, but now we're saying that, in fact, it's enough if there's lots of mutations that worry us, as well as evidence of community spread. And you'll see the link at the bottom will give you some of the definitions of exactly how we're trying to define some of these terms and trying to understand, and how we ourselves try to explain to each other what community spread might mean and what would make a variant under monitoring. The growth advantage, we need to look carefully if it's growing, if it's replacing all the other lineages. And then very importantly, we need to look at other indicators of immune escape, growth, and severity, and also not to ignore therapeutics and diagnostics. So in doing this, we've tried to put it into a framework of a risk assessment framework. And I think that's the next slide. Next. Here you can see, looking at the numbers of the growth advantage. So this is the first thing that we really want to look at before we might move on to a risk assessment, is just to see just how much of this variant is being detected, how prevalent is it, and how quickly is it taking over. And this is very similar to some of the previous tables that we've been showing, is just the prevalence globally by week. And this is from 2022, so the crossover from the last weeks in 2022, first weeks in 2023, looking at prevalence to seeing which ones are becoming more prevalent. And on the right-hand side, you can see it figuratively. One variant may be decreasing substantially as another variant takes over. And I think this is what we want to monitor. It becomes much more difficult as the number of cases that we are sequencing gets less. And so that's the biggest challenge. And that's where looking at recent weeks where things are reasonably stable might help us to understand more what is happening recently under similar surveillance conditions. Next slide, please. So here you have it summarized, the growth advantage, antibody escape, severity, and clinical considerations. And this is the example of EG5. And I think on the next slide, you'll have the link to show you, and there'll be a lot more details. But whether we think the level of risk of each of them is moderate or low, and the level of confidence, whether it's moderate, low, or high. And so this takes lots of discussion. It's not a foolproof methodology, and you will definitely have people that think something might be another category of moderate or high, etc. So it's not like we all have consensus on this, but it's a method to try and understand just how important this variant, this new lineage or sublineage that is emerging, where should we put it and place it in our consideration of then having a public health response. Next slide. And so here's some of the text for the EG5 risk evaluation. I'm not going to go through it in detail, but in general, what we wanted to do is get an overall assessment with thoughts that tells us, well, it tells us EG5 may have a low risk generally of being an emerging important sublineage. The confidence in the risk assessment is also low because we have very little data, and it's because of all the challenges that we've discussed and Maria highlighted from a surveillance point of view, but it may be the baseline data that we're going to have into the future, where we know there's lots happening that we're not detecting, we're not testing, there is some testing, some detection happening, and it's at that level that we need to understand what is going on. So at the moment, the recommendation is that we need to get more data, more in vitro data from laboratories, and we keep on looking at the data to have a dynamic process of our risk assessment. Next slide, please. And just to finish off, this is EPI-2.86, where we have really very few specimens or sequences globally. There's more than 20 mutations in the spike compared to XBB 1.5, and even more if you consider all the mutations in RBD. However, and this is part of the reason it was detected in multiple countries, and you can see, and there's definite community spread in some of those countries. So this is the reason why, even though there are very few sequences and there's not this massive growth advantage that would be another reason to make it a variant under monitoring, we have made it a variant under monitoring, and we're keeping an eye on it and trying to gather more information, get more data. Next slide, please. And you'll see some of the data comes out of laboratories, and this is live virus neutralization data from South Africa, from Alex Siegel's laboratory, telling us that at least with one isolate of BA2.86, that it may be very similar. The neutralization of antibodies, so serum from individuals that had breakthrough infections with different variants, and you can see the different variants on the far right-hand side. You'll see that, in fact, it looks quite similar in its immune evasion, in its neutralization to XBB 1.5, which is good information to have. I think this needs to be corroborated. There's some pseudovirus neutralization data that is also showing us that this might be the case. And these are the data that we need to collect and then review and need to debate about in order to help us to make decisions going forward about the risk assessment of this variant. Next slide, please. In addition, what is very comforting is the lab starts to gather information about what does it look like in the laboratory, what are the viral properties of this strain, does it look different to XBB 1.5, and things are looking that it might be quite similar, so things haven't changed so much phenotypically, so the way the virus expresses itself and does things physically, at least on the in vitro level, and it looks like potentially also clinically amongst people and human-to-human transmission. But we needed to pay attention to the genotypic information that told us that there were lots of mutations. And this is part of the tensions that we have, that we're trying to understand, well, what do the variants and the sublineages and the genotype tell us, and how does that translate, again, into the physical properties and the public health risk within our countries. Next slide, please. So in summary, we have EG5, about 30%, so it's the most prevalent at the moment. XBB 1.16 and XBB 1.5 are also important still, and yet BA2.86 is definitely something that we should be monitoring. It has lots of mutations, the data are limited, numbers are limited. However, lots of public health experts and laboratory experts throughout the world are looking at these strains to see what's going on. Next slide, please. And just to thank, I think, all the people involved in getting these data, putting them together, summarizing them for us to evaluate, as well as for you to see, the technical advisory group, and then the global community, all our researchers and scientists, to make it possible for us to have data, to be able to talk about data and to work out what we should do next. Thank you. Over.
So thank you so much, Anne, for this presentation. I'm going to open up the Q&A. Supriya is kindly helping to send me some questions by WhatsApp as I was sharing my screen. We have about 20 minutes for Q&A, a little bit less while I hand back to Supriya to do some closing remarks. So I encourage you to put some questions in the Q&A section, not the chat part, because we can't monitor that very well. I should tell you, and I think if Supriya didn't mention this already, that we will make slides available. That's always a question that we get. So we will make those slides available, and there will be a recording of a link of this online so you can look at it and share later. So a couple of questions I'm going to start with. that I'm seeing here. The first one is, and we get this question a lot, is BA.2.86 part of the Omicron family, or is it not part of the Omicron family because of the large numbers of mutations? How does WHO see the possible classification questions and related concerns? So maybe, I don't know who wants to start with that. I'm tempted to start with you, Mira, because we have you on the panel, and we would love to hear from you, but maybe we can ask across the panel. So Mira, over to you.
Thanks. Yes, it's one that we have discussed very regularly and an important question. I think mutations really need to act as a trigger for us to consider that question rather than the full definition on their own. So the number of mutations of BA.2.86 was unusual, and it acted for us to trigger, if you like, an enhanced sort of characterization and risk assessment. However, based on what we've got through that risk assessment so far, and it is a very preliminary assessment, as Anne has already said, we don't see features which take it away from the rest of the Omicron family, either in terms of the antigenic distance, so how our immune system sees it, nor in terms of how it's behaving in the laboratory in very early data. So without those changes, I think it would be difficult for us to justify calling it something separate from Omicron, even despite that apparent large number of mutations at the moment. Very important that we continue to update that risk assessment with the new data that comes in, and as we see how it behaves in real life, not just in the laboratory. I think that's where we are at the moment, Anne, but you may want to add to that.
No, I agree fully. I think that's exactly right. I think we're waiting to see more data, but it's definitely still part of the Omicron family at the moment.
Thanks. Lorenzo, do you want to add anything?
No, just I think Mira has made very important points. I think the mutations trigger our interest, but then I think that we have to look at the epidemiological and the laboratory data, and there is no, for the moment, hint to tell us that this is not part of Omicron. But of course, the risk assessment is still ongoing and will be updated as we continue to monitor.
Thanks, Lorenzo. Thanks, Sam. Thanks, Mira. I think one of the most critical things you said, Mira, is right now, with the information that we have right now. I think that's one of the things that has been so striking during this pandemic, is that as we learn more information about any topic, whether it's variants or something else, it's with the information we have at the time, and we reassess, we reevaluate, and we course correct or we change where necessary. So thank you for that. But that's a question we get quite often. There's quite a few questions around wastewater surveillance data and how we utilize wastewater surveillance data. So the question is coming, will WHO encourage countries to share wastewater surveillance data? There's another question that says, is the WHO going to encourage member states to gather and share wastewater surveillance data? Currently, few countries share this data, and there's no global standard for the way it is normalized. Will WHO coordinate this kind of surveillance effort? So we can answer from a WHO point of view, but I'm also interested in how South Africa and the UK, just as examples of how you've utilized wastewater surveillance. For us, we consider wastewater surveillance as an important component of surveillance as a whole. We've seen its utility in polio for many, many years, and we've seen it for SARS-CoV-2. And maybe I can ask Lorenzo if you can comment on some of the data that we're seeing from countries and how it's been used. But I can tell you that WHO and our internally, we are coming together across many different programs, many disease areas, with our WASH colleagues, to come together with a common approach for how wastewater surveillance can be used for pathogens with epidemic and pandemic potential, noting that there are different characteristics of these pathogens, viruses or bacteria. There are many different wastewater surveillance systems in countries, and there's different objectives. Are you trying to use this for early detection? Are you trying to use this for monitoring trends? But we need to have an approach, because right now there's a lot of people interested in wastewater. There's a lot of funding being targeted for wastewater, and that's wonderful. We encourage that, but we want to make sure it's optimized and that we don't take funding away from really critical systems like PCR-based surveillance, our sequencing capacities. But maybe I'll go to Mira, if you can talk a little bit about in the UK, and then Anne in South Africa, and then Lorenzo, if you could comment on how we've seen it used, wastewater has been used during the pandemic. Mira?
Thanks. So in a way, we may not be the best people to start with in the UK, because at the moment we don't use wastewater for SARS-CoV-2 surveillance. We, I think I would say, are in an exploratory phase. We did use it during the pandemic, the early parts of the pandemic. We have data which we think shows that it can be used to monitor SARS-CoV-2 trends, so the epidemiology. And I think what remains challenging is whether it can be used to detect new variants as opposed to monitoring trends in variants that we already know about. And that's what we're quite interested in exploring. I thought this was a very interesting feature of the very early assessment of BA.2.86, that we had countries that could very quickly pick up a new variant as soon as there was a whole genome early, sometimes before their clinical cases were detected. And that was a very interesting use case that we would like to explore. But at the moment, we do not actually have that running, very much learning from the rest of the world on some of that. I also agree with Maria that I think the use case and the model needs quite a bit of development in terms of actually what are we trying to sample. They can be large and quite expensive systems, and are there ways that we can make these cost-effective, easy to implement, effective surveillance systems that can run alongside testing. So I'm afraid that was an early viewpoint from the UK, and I'll hand over to Anne perhaps for the more advanced one.
Thanks, Mira. Anne?
It's just useful if you think about that we're not testing people. So one way of to test, and you can think of this for polio and for other diseases, testing what's in the environment does help us to understand what is being transmitted when we're not testing individuals all the time. We find it very helpful to tell us about trends. So we correlate it to the clinical data, to the case data, and you can see some trends. But I think Maria talks to the fact that you need baseline data. It needs to be implemented. You need to have it running for many months, if not years. You need to understand what it looks like from a baseline point of view, and then you can see fluctuations and trends. And yes, for BA.2.86, it was useful to find the mutations. So what you can't necessarily find is put all the mutations together to give you that lineage, but what you can do is find the unique mutations and show that there might be broader transmission than they might have been detected if you're just looking at cases. So it has been useful. I think there's lots of work being done globally. I think there are regular reports from the NICD on the NICD webpage, and we know that even in South Africa, there are different groups like the MRC, the Medical Research Council, and other groups are also delving into wastewater. And I think this is to be encouraged. It may give us data, but you're right, Maria, I think we need to be careful in how we interpret the information. Over.
Thanks, Anne. Lorenzo?
Yeah, just to add that I think there are systems, the surveillance system that are really critical. And for example, the wastewater surveillance does not tell anything about the severity of and the impact of a variant or SARS-CoV-2 in general, but it does provide an understanding of the spread in the community. And so I think that's it can be a useful tool when it's complementary to existing systems that are also critical importance. I think Mira has mentioned with the recent emergence of BA.2.86, there has been at least a couple of countries from Europe that have detected the variant before in wastewater before they detected in clinical cases. So I think that's an interesting use case, and I agree with Mira that should be further explored.
Thank you, Lorenzo. So we have one specific question on what are the public health implications of the new variant? I'm assuming this is the BA.2.86. So maybe you can comment again on the risk assessment or the elements of risk assessment that are done for our variants. What can and we can't say. I know we covered this a little bit in the presentation, but maybe you can reiterate what it is we know. And does it change any of our interventions? Do we need to change any of our interventions? Who wants to take that one?
Mira can have one for you, maybe.
Or Mira? Oh, Mira, Anne just tagged you in answering that question.
I can have a stab at it, Anne. So I think it is a little bit linked to the answer that we gave earlier about the fact that we still see this very much within the Omicron family. So what we know about this so far, we've got this sort of early lab data that shows us that BA.2.86 has evolved. It is a bit distant antigenically, so the way that the immune system sees it from earlier Omicron waves, but it is quite similar to other circulating Omicron lineages at the moment. So it hasn't gone further than those necessarily. And we don't see, again, from very early laboratory data, anything that suggests it's changed the way that it behaves as a virus. So in the cell cultures or anything else that we can measure in the laboratory. And even though that's early days, that doesn't suggest that it's going to have a change in impact from, I think, other circulating Omicron lineages, particularly. I think we've already identified that it's been quite hard to understand its growth. So growth is obviously a component, a sort of mixture of lots of different components. It takes into account the virus's immune escape, its transmissibility, the population immunity, and potentially some behavioral components may contribute. And it's very early days with the number of sequences that we have at the moment to understand whether this is a variant that has a growth advantage that may come to dominate, that could drive any transmission, or whether it's just going to circulate as part of a mix of Omicron variants, or indeed whether it's going to die out. So I don't think we can speculate on that part of the impact it will have on transmission, but otherwise it looks very much like the rest of Omicron really at the moment. And is that reasonable representation discussions?
Always good to have other people saying things in different ways. But I think for me as well, public health means just how many infections that's engrossed, or how many people are getting sick, whether we can count them or not with specimens, and how many people are presenting to clinicians, GPs, public health institutes, so that is part of the public health pressure that you might want to monitor. And then admissions in ICU, severe disease ICU admissions. And at the moment, there doesn't seem to be much of an indicator that that's happening, but that's part of the public health, the parameters that one would like to monitor.
Thanks, Anne. Thanks, Mayor. I just want to reiterate that there are many public health interventions, medical interventions that we have for COVID, including all of the variants that are in circulation that continue to prevent infections, reduce the risk of developing severe disease, reduce the risk of developing post-COVID condition, reduce the possibility of dying from infection with this virus. And it's not just vaccination. We have many safe and effective vaccines that are out, that are in use. And what is really critical is that individuals get vaccinated, but also look at when your next dose is necessary. For us at WHO, we want to ensure that people who are in the at-risk groups, those who are of older age groups, who have underlying conditions, pregnant women, our frontline workers, are receiving additional doses within 6 to 12 months, depending on your risk category. So it's not just important if you got boosted, but when you got boosted, and that remains really important. But it's not just vaccines. It's early access to diagnostics and clinical care. We have many therapeutics that prevent the development of severe disease, but also prevent dying. We have masks, respirators, personal protective equipment. We need better improvements in ventilation, where we live, we work, we study. There's a whole spectrum of interventions that continue to be needed and used for COVID. And again, not just good for COVID, but good for other pathogens that are in circulation. So I just wanted to make that point. We have a couple of questions which reference data coming from countries in Africa. So one question is, the data from Afro countries is low. Can this be due to health system challenges? There's another question that says, from the map shown, it seems sequencing is not done by most countries. How can countries like the Gambia be assisted in this area, considering the fact that we have one of the highest mortality rates of COVID-19 and also with the lowest rate of voluntary testing? Maybe, Lorenzo, I can start with you on the work that WHO has done through our regions and countries and with our country partners on increasing sequencing capacities.
Sure, I think it's clear that there are surveillance blind spots, and I think, Maria, you highlighted in your presentation when you showed that there is very little data that is shared from 3 of the 6 WHO regions, namely CRO, so the Southeast Asia, the Middle East, and the African region. And I think there are different reasons for that, including willingness to share data, but mainly is also, especially for the Afro region, certainly is also because the sequencing capacity is there but can be improved, and so that's why we're working with with countries and specifically also with laboratories on capacity building activities and making sure we try to shed some light onto those surveillance blind spots. So I think that's what we are aiming for and what we have been doing in these years.
Thanks, Lorenzo. And do you want to comment on, I mean, because the sequencing work in particular from South Africa has really been outstanding. in the last several years. And you worked really hard to expand surveillance and different capacities across the country, but this is happening across the continent as well. And I think it's important to highlight that, and I would like you to comment on this, right? Because we're not in the same place we were 4 years ago. The amount of PCR labs, the amount of sequencing capacity is really incredible. Somalia had no PCR capacity before. They can test, they can sequence. These are capacities that this needs to be part of the legacy of COVID for the future. Certainly, maybe not at the same level that we were seeing during the peak of the pandemic, but what is your view? I mean, South Africa, one of many countries across a very large and diverse continent, but what are your views on this?
I agree. I think many countries in Africa have been testing, doing PCR testing, and are really using this opportunity to use it as with momentum to test for other respiratory viruses, to consider very much the gizzards syndromic surveillance, trying to do something in a standardized way, not only looking for SARS-CoV-2, but looking for influenza, RSV, and other pathogens that are important for those countries. So I think there's been a tremendous amount of movement to try and improve this, and it's really happening. And sequencing, even I think sometimes we don't see that even just a few sequences from some of those countries, they are happening, and these countries are managing to sequence SARS-CoV-2 and now other respiratory viruses. There's a lot of work being done in trying to train, to sustain training, to have follow-up so that we don't work alone, so that we're working together, because many of us struggle. We have staff turnover, but then new staff come, we have the machines, they don't always work, but there's lots of networks that are being built within Africa that I think really will make a difference. And I think my hope is that the momentum of the pandemic will really move us forward for so many other diseases, as well as to monitor SARS-CoV-2 going forward. Over.
Absolutely. Thank you so much, Anne. Mira, did you want to comment? We're coming to the end, but I want to give you a chance to say anything else before we close.
No, nothing to add from me. Thanks, Maria.
I saw you nodding while Anne was speaking, so I was thinking you were agreeing there as well. So that's great. So we're coming to the end. It's the 1 hour. I know we could probably keep talking about this for another couple of hours, but we all have to move on to our next meetings. So thank you so much, Dr. Mira Chan, Professor Anne von Gottberg, Dr. Lorenzo Subisi. Thank you to the entire EPI-WIN team, led by Sylvie Briand. Supriya, we appreciate you and the whole team helping us to organize this and giving us an opportunity to talk about this really challenging topic. So back to you. Thanks again very much.
Thank you very much, Maria, and thank you to Sylvie, who's been leading on this, and to all the wonderful speakers. But thanks also to all the people who attended and for your interest and very interesting questions. And I hope you feel some of your concerns and queries have been addressed by the top experts in this field. I'd like to thank everyone for making this webinar possible. Dr. Sylvie Briand, Maria, Dr. Mira Chand, Dr. Lorenzo Subisi, Professor Anne Gottberg, the EPI-WIN team, that's my colleague Priya Umachandran, who's been supporting and doing the chat in the background, Jiangfang Liu, who's been helping us with all the tech issues, Dr. Agnesi Pastorini, who is supposed to be on break but has still joined to help us. All the interpreters, we have interpreters in Arabic, Russian, Spanish, French, and also, of course, the organizers of the AI bots. And last but not least, also our IT colleagues, particularly Dragana. Well, as Maria has mentioned, you will get the recording available in all languages on our website. And you will also get a summary digest of this webinar and the topic. If you have any further questions, please do write into the EPI-WIN email. And you will also get a summary of everything we do coming up. So in October as well, we have some exciting webinars coming up. The next one is on vaccines for seasonal influenza and zoonotic influenza, followed by infection control and prevention and control for Ebola and Marburg. So please do join us. Look forward to seeing you again. And thank you very much for joining. Thanks to everybody. Bye.